Welcome everybody. Well, in fact, welcome to 2025. Mr. Tyree Horn, the producer, just told me that this is the first webcast of the year here at DeBakey CV Live. So we are coming to you live from Houston, Texas, Texas Medical Center, Houston Methodist Hospital, DeBakey Heart and Vascular Center. These webcasts are the brainchild of our leader, Dr. Lumsden, and we've been doing these webcasts once a month, except in the summer, on AFib on the first Tuesday of the month at 5 p.m. Central Time. So Happy New Year, everybody. If you did have AFib and you're now AFib free, congratulations. If you have AFib and you're not AFib free, maybe this is the year to do something about it. So again, we'll start out the first webcast of 2025 here at DeBakey on a topic that we have not covered before, and that is CT scan before the Wolf procedure. And by the way, I did change the name to Wolf procedure. Dr. Miranda suggested it, other people suggested it, because it's really not a maze procedure. And we did publish, Dr. Miranda and I published an article about a month ago, and it's free access, so you don't have to be a member of thoracic cardiovascular surgery or AATS to get it. It's open to everyone. And Mr. Producer, maybe you can flash that article on the screen, because some people might want to read it. It was written for other heart surgeons, but I still think you may get something out of it. There's also a video at the end of this article. Mr. Horn and I did this a few months ago, and it's about 8 minutes long, and it's a summary of the Wolf procedure. Now it says Wolf mini maze on here, but we changed it to Wolf procedure because it's not really a mini maze. A mini maze, the maze procedures, is based on the fact that it says you create a maze so the electricity can only go one way. But that's not really, I think, what makes things work. It's really the partial cardiac denervation. It's interrupting these autonomic nerves that are on the outside of the heart. We've talked about this before. So it seemed a little misleading to call it a mini maze. and we should call it the Wolf procedure, which is a cardiac denervation and closure of the appendage and testing the nerves. And you can see in this article, if you like, it's called a new solution to an old problem. And Mr. Producer is going to go back to the top there, and we'll leave it on the screen for a minute there, George, so that everybody can see it. Minimally invasive surgical treatment of atrial fibrillation, a new look at an old problem, and it is on operative techniques, Journal of Thoracic and Cardiovascular Surgery. And as I said, this is open access, so anyone can get this off the internet, including the embedded video. You should be able to open that as well. Well, as is mentioned in this article, we do preoperative CT scans on patients before the Wolf procedure. And many patients have questioned this. Why is this important? And I thought it was worthwhile going through with you some of the reasons that we do this. And I think once you hear this, you'll understand it's very important to have this test before the Wolf procedure, if you can. Why do I say if you can, or if you're able to? They do use some dye, so the radiologists do not like to do this procedure if the creatinine is elevated. In other words, if the kidney function is poor, we generally don't do it because it's kind of a double whammy to have a dye and then have surgery. So that is why the kidney function is always checked first when patients come here to Houston Methodist Hospital for the Wolf procedure. And if the kidney function is adequate, then we do the CT scan, usually the day before, a couple days before. Now, I'd be remiss if I didn't mention we have questions coming in, and we invite your questions throughout the hour, but it's better to get your questions in towards the beginning of this hour, more likely that we'll be able to get to your question and answer it. So we got two ways. If you're on the phone, it's 37607, and then put DeBakey, text DeBakey. If you're on a computer, go to PollEV, that's POLLEV.com, enter DeBakey, and then you can ask your question. So you can ask your question on your computer or through your phone. Either is fine. We're happy to take your questions. We got some coming in, and I think some of these I will probably answer as we go through this CT part. But I'll take any question you have on AFib. It doesn't have to be specifically on the CT scan preoperatively, but preferably that would be nice because that's the topic for today. But I'll take other questions as well. So Dr. Miranda and I published this paper about a month ago, and one of the things that we mentioned here is the pre-op CT scan. A note aside, the plan was to have Dr. Mamarian with me. He is a cardiologist here, and he specializes in reading CT scans of the heart. And he had good intentions of being here today, but he sent me a text message a few hours ago and said that he was running with the dog, hit a stump, fell, and he's fractured his hand. So he's got a personal medical issue right now and was unable to join us. But I've been doing the CT scans for a long time, and I'll be able to fill in for him. No, I'll just stay right here. But I'll fill in for Dr. Mamarian. So the first question that usually comes up is, well, I had an echo. Why do I need a CT? There are two types of echoes. One is where the gel is put on your chest and it's rubbed, and we get an echocardiogram, an ultrasound of the heart. The other is where you swallow the probe, and the echo then is inside your esophagus, which gives a pretty good look at the heart and the back of the heart. Unfortunately, it's not uncommon to have what we call a false positive echo. What's that mean? it means that the echocardiographer says, I think there might be a blood clot in the heart, and usually specifically it's in the left atrial appendage. Now they say, I think, I believe. There's a likelihood that there's a clot in the appendage. And over the years I would see this, and we would not do a minimally invasive procedure, we'd do an open procedure so we could remove the clot from the appendage. But after about 5 of these, it occurred to me that something was amiss, because of those first 5 patients where we opened the appendage, there wasn't any clot. So how did we get from a respected cardiologist saying there's a blood clot in the heart, but at the time of heart surgery we find no clot? Well, these are called false positives. And it occurs because sometimes the appendage may fold over on itself, or the flow may be very slow in the appendage because the patient's in atrial fibrillation. They say smoke, there's smoke in the appendage, there may be a clot. So it became clear to me we needed a better way to address this. And about between 15 and 20 years ago, when I was teaching at the University of Cincinnati, the radiologist and I came up with a better solution to see if there really was a blood clot in the heart, and specifically the left atrial appendage. And that was to do a CT scan. Now the CT scan sometimes misreads it as well and says, well, there might be a blood clot in the appendage. So we came up with a modification of the CT scan. This was presented in Chicago at the big radiology meeting probably 15 years ago. And it was called the 60-second solution. And what it is basically is you do the CT scan, then you wait about a minute and take another shot. And that gives the dye more time to circulate in the heart in places where the blood flow is very slow, which is the left atrial appendage. And using this technique, we had no false positives. Every time the CT scan said there's no blood clot in the left atrial appendage, there wasn't. So it's very predictive, much better than an echo. So for those of you out there who have been told you can't have this or that, and you got to stay on blood thinners because you got a blood clot in your appendage, on the echo, you need to get a CT scan with a delayed image. And that's what we do here. And one of the reasons that I recommend people get their CT scan here at Methodist is because Dr. Mamarian is here. He does a beautiful study. He reads them right away. He calls me if there's anything suspicious, so we know right away and we can address it. We've seen CT scans from other institutions, and they didn't have a delayed study. They were read with blood clot in the heart and other things when that really didn't exist. The other advantage of getting the CT scan just a couple days before the procedure is that there's little time for anything to change. So if a CT is a year or 2 old, things could have changed in that interim. So that's how we started out. This was at University of Cincinnati 15 or 20 years ago, the 60-second solution. And I've been performing the CT scans like that since then. Now, that's not the only reason. That's how we got started on this road of preoperative CT scan. But we've seen so many interesting findings preoperatively that are very important. They're important for you, the patient. They're important for me, the surgeon. And I'd like to go through some of those with you. We'll take a short break here and go to a couple questions. And the first one is related to the topic at hand. Dr. Wolf, please explain the difference between a CT scan and an MRI and their uses related to cardiology. A CT scan is an X-ray. It's multiple X-rays. X-rays spinning around and then doing reconstruction, showing the inside of whatever body part you're scanning. In this case, we're talking about the heart. They're very detailed. They can show coronary disease. An MRI is magnetic resonance imaging. And in that situation, you're placing the body inside a huge electromagnet. This electromagnet stimulates the electrons, and the electrons move to a different orbit. Then when you turn the machine off, turn the magnet off, the electrons drop back down into their regular orbit, and they emit energy. And it's that energy that is studied by the MRI. So they're two completely different types of studies. The MRI does not have any X-rays. On the other hand, I think most of the time the anatomy is very better delineated, specifically in the coronary arteries with the CT scan. Now keep in mind, a coronary artery is very small. A coronary artery is about a little bit bigger than the tip of this ink pen. Very small, but a CT scan can see that very nicely. Now one of the advantages of an MRI is you get more function. A CT scan is more anatomy. It does not generally show the function, although one of the things that Dr. Mamarian was going to talk about was the fractional flow reserve. There is a way now to measure the flow in the arteries based on an algorithm of looking at the CT scan. Now it's not 100%, but it's pretty good at predicting who might have significant blockage on a CT scan. So currently what's done today, if the CT scan is performed and it looks like there might be a significant coronary blockage, then the fractional flow reserve is calculated from the CT scan to suggest if there's a significant flow lesion, a significant flow problem in the coronary artery. And we do that here at Methodist as well. So for the anatomy, I prefer the CT scan. We can see the coronaries very nicely. If you're more interested in function, you may go the MRI route. But that's for us, for the bang for our buck's more on the CT scan. Dr. Wolf, can the Wolf procedure correct vagal AFib? Absolutely. And in my mind, all lone AFib is vagal AFib. All of it. And I believe this is a basket of diseases that are all related to abnormal activity of the autonomic nervous system, whether it's AFib or aflutter or inappropriate sinus tachycardia or postural orthostatic problems. I think these are all related to the autonomic nervous system, and the vagus nerve is a big part of the autonomic nervous system. Are saunas and steam rooms contraindicated for AFib patients? No, not at all. And I don't know if you mean pre-op, post-operative, just if you have AFib. I guess we'll just say AFib. I think you have to be a little bit careful because not so much the AFib, but the medications that are prescribed for AFib. A good example is a calcium channel blocker. Diltiazem is an example. Well, these are vasodilators. They dilate your vessels a little bit, and they also slow your heart rate. And if you have a vasodilatation anyway from being in the sauna or steam room, you could get low blood pressure more easily if you're on a beta blocker or the calcium channel blocker, either one. So I think it's probably more related to medications that you might be on. And if you're on one of these medications, a beta blocker or a calcium channel blocker, you should check with your physician and see if it's okay. And it might be just maybe too much vasodilatation doing a sauna if you're on a high dose of calcium channel blocker, for example. Is thoracoscopic surgical ablation similar to the Wolf procedure? It is. It all started with the Wolf procedure. The only difference in the thoracoscopic is that there are 4 or 5 holes as opposed to 3 holes with the Wolf procedure. So you have more holes that are smaller, or you have 2 small holes and a bigger hole with the Wolf procedure, but it's the same. And Dr. Schneeberger and I did totally thoracoscopic maze procedures 2004. But we found that they were a little more difficult to do. Very difficult if the patient had other issues such as scar around the heart, and it seems safer to do this 2 small incisions and what I call the working port as opposed to the 4 small incisions. We even did some patients where we did the totally thoracoscopic on one side and what was called at that time the mini maze on the other side, and the patients really had more pain on the totally thoracoscopic side. So we didn't see any advantage with respect to healing or pain. So we stuck to the incision the incisions that are safer, but it's pretty much the same procedure. Questions are coming in. Here's one. Can I have a CT scan if my iodine levels are elevated due to medication that I'm taking, such as amiodarone? Yes, you can. That's fine. Amiodarone is a very effective drug. The key, and we did a webcast on this probably 5-6 months ago, I think. And we discussed the amiodarone in detail. About 30% of amiodarone is iodine, but that's what makes it work. So we try to limit it to a year or less of taking the amiodarone, and the key is low dose. And Dr. Fahad and I discussed this in detail, and you can go back to that webcast. It is a DeBakey CV Live, and you'll get the lowdown on that in great detail. Let's see. I'm 54-year-old female, 198 pounds. How much weight do I need to lose before we schedule the Wolf procedure? Let's see. It depends. It depends on your height. That's the key. That we use the BMI, body mass index, and that is calculated from your height and your weight, but not your age. So it depends on how much you weigh, and I have a little calculator on my phone. We like to see the BMI about 32 or less. We'll go up to maybe a little bit bigger than that depending on where the weight is. Some people mostly have the weight on their lower body. It doesn't affect their chest that much. But I don't think I can answer your question without knowing your height. Now I'm gonna stop the questions for a minute and get back to the talk. Again, the topic is why are we asking you to have a CT scan preoperative before the Wolf procedure? Well, one I already answered. We want to make sure there are no blood clots in the heart. If there are blood clots in the heart, which is rare, those could break loose during the procedure and cause a stroke. So that's a big deal. Secondly, we want to look at the anatomy. Not everybody has the same anatomy. We're doing a patient tomorrow from Chicago, and they have a common left vein. What does that mean? Well, normally there are two veins that drain into the heart on the left side from the right, and two that drain in from the left. And this patient has one vein on the left. It's the most common non-classic anatomy that we see. But it's nice to know that before we go in there. It helps me with proceeding during the procedure, in this case on the left side. There have been many other cases that are noteworthy. We've seen patients who've had multiple catheter ablations, and they have a blockage of the vein from the burning of the vein from the catheter ablation. Well, we want to know about that before we go in there to do a Wolf procedure. For a couple reasons. One, I've seen them where they're completely closed off. That's called occluded. So a vein is closed off, and that leads to high blood pressure in the lung. And these things have to be treated differently. So we definitely want to know if you've had an ablation that there's no blockage in the vein from the previous ablation. And this can be sometimes hard to treat too, but we have to know that. We can see if there's any valve disease. We've had patients that have had a large left atrium, and we do the CT scan. We find out they have significant leakage of the mitral valve. That's the valve next to the left atrium. And in fact, they need an open procedure and a new valve. And at the same time, we do the Mays procedure. And maybe one of the most common things we see that are unexpected are significant coronary disease. Now, we had a patient a few weeks ago, had the CT scan, and John Mamarian called me and said, this fellow looks like he's got some pretty significant coronary blockage on the CT scan. We did a fractional flow reserve to see what the flow was from the CT scan, reconstructed the images, and it looks pretty significant. So I saw the patient and I talked to him and I said, do you ever have just chest pain when you exercise? He goes, well, doc, as a matter of fact, I think I do. And I said, well, I think you got significant coronary disease and you have angina pectoris. So we postponed his procedure. We had a heart cath done while he was here at Houston Methodist. And Dr. Dukeman did it. And in fact, he had very significant coronary disease. And in these cases, we go ahead, in this case, a stent could fix it. So we did the stenting of the coronary artery, and then we'll wait and we'll do the Wolf procedure later. Now, the idea here is to treat the coronary problem before you have heart surgery, if you can, and stents are very good at doing that. There are some patients that we found that have significant disease that are not candidates for stent. In those cases, a few of those patients have had coronary bypass, or CAB, as sometimes it's called, or a CAB, and then at that time we do the maze type procedure. So it's important to know this before the Wolf procedures, because sometimes we have to change the procedure that the patient really needs. Another bit of information we get that's very helpful is what's the size of the left atrium. In my experience over the last over 20 years, and this has been documented by Dr. Cox and others, if the left atrium is quite large, more than 200 milliliters, then the chances of staying in rhythm after the procedure start to go down. They don't just go down to zero, but they start to go down. It may not be 95% anymore. And it's nice to know that before we go in. Plus, if it's a very large left atrium, from a technical standpoint, that's very helpful for me to know. We also look at the size of the aorta. Sometimes the aorta is quite dilated, enlarged. One of the patients who we did today from Idaho had that situation. A normal aorta is about 2 centimeters. Twice that size would be 4 centimeters. If it's more than twice that size, we start to watch it every year, and his is 5 centimeters. But his aorta has been watched every year, and it was 5 centimeters a couple years ago, and on the CT scan yesterday it was 5 centimeters, so it hasn't changed any. So it's not gotten any larger, so we continue to observe it. But that's one of the things we want to know before we do the Wolf procedure. And if it is enlarged, it's something we want to follow each year, because if it starts to enlarge more, dilate more, then something really has to be done. That aorta should be replaced because it's at higher risk of bursting. Lung abnormalities, we've seen many of those. Sometimes I have performed a lung procedure at the same time as the Wolf procedure. We can kill 2 birds with 1 stone. Sometimes it's a biopsy, sometimes it's a removal of a nodule, and this has saved the patients extra years and years of follow-up with scans, or even finding out that they have some malignancy very, very early on. And we can see those on the CT scan. All right, now let's go back to a couple questions. I'm based in the UK and under a NHS, that's National Health Service, cardiologist. I've been in the waiting list 1 year now for an ablation for AFib. I recently learned about the Wolf procedure, want to head to Japan for the procedure. Will my cardiologist work with the team in Japan? If so, what information needs shared? Well, one of my proteges is Dr. Otsuka, and he calls it the Wolf-Otsuka procedure in Japan. He does a very nice job, and for some people based in Europe, it's less expensive to go to Japan than the United States, and it's just based on the hospital system. But it's specifically what you might need. I don't want to speak for Dr. Otsuka completely, but mainly what you need is an echocardiogram within the last year or two, and an EKG that shows your heart out of rhythm. We want some documentation that your heart is or was out of rhythm. So an EKG and echo would be the minimum, and Dr. Otsuka can probably take it from there. If you have information from your cardiologist. It's very helpful to have a copy of those notes and send those to the surgeon so they can also review those. How do you determine whether the Wolf procedure will work on the type of arrhythmia a patient has? Does the Wolf procedure work on all arrhythmias? Okay. Well, there are a lot of arrhythmias, but that's specifically pared down to the atrial arrhythmias. And the most common being atrial fibrillation, probably second most common atrial flutter. There are different types of atrial fibrillation. There are situations where the heart is out of rhythm all the time and it's been out of rhythm for over a couple years. That's chronic AFib. It could be a situation where the AFib comes and goes and lasts an hour or a day. That's paroxysmal AFib. It could be a situation where the patient goes out of rhythm for more than a week or has had to have a cardioversion or a shock to the heart to get back in rhythm, and that's called persistent AFib. So you got paroxysmal, persistent, long-standing, persistent, chronic. The good news is, in my experience, the Wolf procedure works on all types because we address the nerves. The only caveat is if the heart's been out of rhythm for a very long time, many, many years, and the left atrium is greater than 200 milliliters or contains greater than 200 milliliters of blood, then the chances of being successful in getting back in rhythm start to go down. But there still is another goal, and that is to close the appendage to decrease the risk of stroke. So most people who have a large left atrium say, well, let's go for it, Dr. Wolf. I can get off blood thinners, that's my main thing, and if it gets me back in rhythm, that'll just be icing on the cake. So, in my opinion, it works for all types of arrhythmias, and we have 20 years of follow-up. We have people that had long-standing persistent AFib 20 years ago, and they're still AFib-free. Atrial flutter. Atrial flutter is where the top chambers of the heart are going faster than the lower chambers. This is not AFib, but the upper chambers are beating, but they're beating too fast. If a patient has not had a catheter ablation, has not had a catheter ablation, then a catheter ablation is the best way to treat a flutter. Over 90% success rate. If the patient has had previous ablations, then it's usually left-sided flutter from the ablation, and then a Wolf procedure is very effective. So if there have never been ablations before and the patient presents with flutter, best treated with catheter ablation. If the patient's had previous ablation, the Wolf procedure is very effective in stopping that type of flutter. If the patient has inappropriate sinus tachycardia, very nicely treated with the right-sided Wolf procedure, and I wrote this up in the Annals of Thoracic Surgery in 2007, a long time ago. I believe if the patient has POTS, postural orthostatic hypotension, again, an autonomic problem, that the Wolf procedure on the right side is very effective. If the patient has other arrhythmias beside that, that's really not what the Wolf procedure was developed for, so I really can't say about the other ones. But the ones I've mentioned, I feel very confident that the Wolf procedure can help in with over 90% success long term. Dr. Wolf, after the ablation I had last year, my heart has a difficult time coming down to a resting rate after exercise. Will the Wolf procedure, and then it stops. So I imagine you're saying, will the Wolf procedure correct this? Yes. Generally what you should look at is what's your resting heart rate. If your resting heart rate's 90 or 100, you may not be in rhythm. You may be in flutter. I think you should have a good EKG and make sure that you're not in flutter, because it sounds like flutter. And in flutter, what will happen if you start to exercise, the rate will jump up to 130, 140, 150. Typically, it's 132 or 134 beats a minute. So my first question would be, make sure you're really in rhythm. If you're not in rhythm and if you're flutter, then this could be corrected by the Wolf procedure, definitely. Dr. Wolf, if I schedule surgery a year out and I'm currently in AFib, do you recommend cardioversions or ablations prior to the Wolf procedure to prevent remaining in AFib the entire year? Also, I assume the Wolf procedure is effective with regular and slow AFib. The Wolf procedure is effective with regular or slow AFib. Usually slow AFib is the result of taking medications such as calcium channel blockers or beta blockers or amiodarone. What I recommend is not an ablation because that scars the heart on the inside and can lead to atrial flutter. My recommendation is to start low-dose amiodarone unless you have some contraindication to that. Low-dose amiodarone is very well tolerated, and again, you can go back to the webcast that I did with Dr. Fahed months ago and look at what we discussed about amiodarone. Low-dose amiodarone for 8 weeks, then a cardioversion. And that should get you back in rhythm, and you'll be fine until you have the procedure. Dr. Wolf, you do a CT scan for heart disease and other abnormalities prior to the Wolf procedure. After doing some research, I see that it contains the highest amount of radiation of all other CT scans. It's equivalent to being out in the sun for 4 straight years. Is there any other way, any newer technology, that you can use instead of this dangerous radiation? Well, the good news is we have some new CT scanners, and the radiation that is delivered during these scans continues to go down significantly. And what's done here are called gated. The CT scans are gated, so they're gated to the heart rhythm, and that dramatically decreases the amount of radiation plus some other things that they do. So I think everything's a risk versus benefit, isn't it? Specifically in medicine, what's the risk, what's the benefit? It's never, there's no risk and it's all benefit. Just like betting, there's a risk and a benefit. But in medicine, we look at that risk-benefit ratio. And if the risk is relatively low and the benefit is relatively high, then your risk-benefit ratio is very good. Well, in my opinion, your risk-benefit ratio CT scan is extremely high. Let me give you another example. This just comes off the top of my head. This is a patient who came from the Midwest, had already had 3 ablations. They failed, and the patient came here for the Wolf procedure. We did the pre-op CT scan. Dr. Romarian called me and said, this is really odd, but all of the veins in this patient don't drain into the left atrium. The veins come, your heart is really 2 pumps. One of the pumps pumps the blood to the lungs. The other pump pumps the blood around your body. And when the blood comes back from the lungs, it goes into the left atrium through usually 2 veins on each side. Well, this patient had 1 vein that drained into another chamber of his heart. Now, how could he had 3 ablations? How could they do an ablation if one of the veins doesn't even drain into the left atrium? Because you get to the veins with catheter ablation by going into the left atrium. But anyway, I mean, he needed a different operation. And the operation we did on this patient was to redirect the vein that went into the wrong chamber into the right chamber and do the maze type procedure. And that was a few years ago, and now he feels better and he's AFib free. But all the catheter ablations in the world aren't going to work if the veins don't even drain into the proper cavity. So we pick up these things where you think, well, maybe that should have been sorted out when he had the catheter ablations, but they're simply missed. Another patient, and I've seen about 4 of these now, had a left SVC. What the heck does that mean? Well, normally all the blood from your head and your arms drains into what's called the superior vena cava. It's a big vein that goes into the top of your heart. But some patients also drain the blood from their head and their arms onto the left side of the heart, and then it scoots around and goes into the right side. Very nice to know that before the surgery, and the CT scan will pick up on this. Here's a good example. This is another patient. I mean, these are real cases, people. You can't make this up. He originally from Canada. He did commercial real estate in Phoenix, but now he lives in La Jolla, up on top of San Diego there. And he'd had ablations, they failed. He had a convergent procedure, not my favorite thing, but he had it, it failed. And then he came to see us. We did a CT scan pre-op. He's got a left superior vena cava. Nobody noted it before on the ablations or his previous surgical procedure. Now it turns out that the left SVC, where the blood drains into the left side of the heart, is very arrhythmogenic. So simply put the clamp across it, fire it. That isolates the left SVC. That patient's now, I think, a couple years out from his procedure. He said he doesn't even think about AFib anymore. He's off all drugs. He's back to flying his plane. He's had no AFib. It's important to know if there's abnormal anatomy, even if they're not having the Wolf procedure, but we can figure out what really needs to be done. Another patient, this is also a pilot from, 7 or 8 years ago. He had AFib, was grounded, but he also had a nerve tumor on his spine. And we could see it very nicely on the CT scan. It's called a schwannoma. It's a benign nerve tumor. It was about that big around. And so at the time of the mini-maze, I also resected his nerve tumor, and that was the end of that. So we also see these other abnormalities in the chest that can be treated at the time of the Wolf procedure, or we can change the treatment to make sure we take care of all the problems. Let's go back to the questions. Been on amiodarone 200 milligrams once a day since early November. Doesn't seem to be helping. AFib has become more frequent. Good idea to continue. I say yes. If you're doing it preoperatively before a Wolf procedure, I would continue it. If you're out of rhythm all the time, get a cardioversion. If you're just out of rhythm some of the time, it may not all be AFib. A monitor would be helpful. You know, I put in the subcutaneous monitors because sometimes you think you're in AFib, but really it's just extra beats. Premature atrial contractions, premature ventricular contractions. So if you're not sure, get an EKG or wear a monitor and see when you have your symptoms what you're really having. Does diet have any role in AFib? Could you control AFib solely on diet? I think it does have a role. I really do, and I think in a couple different ways. Certainly obesity is an issue and leads to more AFib. So if you can change your weight, decrease your weight significantly, get down to a more normal BMI, you may have much less AFib. There are some triggers to AFib that include nicotine-based type of things such as smoking. There are alcohol types of things such as drinking alcohol. So smoking and drinking can cause more AFib. Sometimes drugs, sometimes high doses of supplements. Yeah, supplements can cause more AFib. So certainly trying to decrease some of the triggers is reasonable, but probably the most important thing is getting the weight down to a normal BMI, at least less than 30, BMI less than 30. You mentioned BMI. I've read that this is body mass index based on your height and weight. Doesn't include other factors like race, sex, age, body composition. Does this matter? Well, it does matter. Like I did mention that some people are shaped where most of their weight is on their lower body. That wouldn't interfere with the technical part of doing the Wolf procedure as much as someone who had a lot of weight in their chest. So it does matter. I don't think race or sex or age makes any difference, so at least not for the technical part of performing the Wolf procedure. Do you ever do hands-on demonstrations for your procedure? Question future CV Live. Well, that's a reasonable suggestion. I think first you should look at the edited video that's at the end of that manuscript, that article that we mentioned at the beginning of this talk today. It's in the Journal of Thoracic and Cardiovascular Surgery. That's operative techniques, and it just came out within the last few weeks. And it's pretty good because you only have to watch it for 8 minutes. But we have done live procedures. I've done many live procedures. I've done them here. I've done them in Europe. I've done them in Asia. I'll think about it. It's a good suggestion. Appreciate that. 2 questions. If AFib occurs during the healing phase of the Wolf procedure, are interventions such as cardioversion, amiodarone, or catheter ablation used to optimize long-term success, or are they used for patient health comfort in the short term, or both? Okay, well, leave that question up there, Mr. Producer, because there's a second part to it. Let me answer the first part right now. We do a cardioversion generally 4 weeks after the procedure if the heart's still out of rhythm. And this is generally in people that have had multiple previous ablations before the Wolf procedure or who have an enlarged left atrium. Amiodarone is given to kind of smooth things out. I try to start at 2 months before the procedure, low dose, and about 3 months after the procedure. And that's just so it's more likely the heart will stay in rhythm during the healing phase. The catheter ablation is reserved for people that mainly have atrial flutter, could have AFib, mostly flutter, more than 6 months after the Wolf procedure. But these are all really to optimize they're all optimize long-term success, except for the amiodarone. That's more short-term. But the other are long-term. And amazingly, I still have some patients that take a very small dose of amiodarone. I mean, 1 pill or 2 pills a week, which most cardiologists will say is homeopathic, won't do anything. But it keeps them in rhythm. After the mini-maze, they maybe still have a little bit of something that can get them out of rhythm, and that seems to help. So very, very low dose amiodarone can be in the short term and the long term. The second part of this question is, during the healing phase after the Wolf procedure, what amount of AFib burden or other arrhythmia burden determines if interventions are necessary? The key here is continuous. If there's continuous AFib, continuous aflutter, then other interventions are recommended. If the patient's not on amiodarone, start amiodarone. If they don't convert, do a cardioversion at 4 weeks. And if they really can't seem to stay in rhythm, a catheter ablation may be a reasonable approach at greater than 6 months. Dr. Fahed has had tremendous success with follow-up catheter ablation in these patients with almost 100% success. Okay, now I've cleared out most of the questions, I believe, and I'd like to kind of summarize what we're talking about. The pre-op CT scan has a basis that goes back to 2005. It's very specific, it's very sensitive, and it shows us the anatomy like nothing else. It's helped us on so many patients who either had unknown coronary disease, some anomaly of the heart, which is not that uncommon, which has helped us determine what operation to perform or the way that I perform the Wolf procedure. It's shown us whether or not there have been complications from a previous catheter ablation, such as closure or blockage of one of the pulmonary veins from previous catheter ablation. It's shown us things like diaphragmatic hernia, where in fact the stomach's up in the chest. The stomach's supposed to be in your abdomen, not your chest. And we've seen this on the CT scan. We've corrected both. We correct the hernia and we correct the arrhythmia. We picked up significant valve disease, coronary disease. We picked up lung abnormalities, and we picked up chest wall abnormalities. So in my mind, the risk-benefit ratio is far in favor of getting a CT scan before the Wolf procedure if your kidney function is adequate. We still take this on case-by-case basis, so sometimes there are other reasons why a patient can't have it. Usually if they have some sensitivity to iodine, we pre-treat the patient as if they have an allergy, and that works very well with a antihistamine type of medication. I hope that this has been helpful to you. If you have questions about the CT scan, if you have further questions, don't hesitate to respond on the website. That's Wolf Procedure, aka Wolf Mini Bays, but now known as Wolf Procedure. Facebook is okay, but the website would be better because those questions would come directly to me, and we're happy to talk about it some more. I believe we're on, Mr. Producer, for next month. The answer is yes. Yes, got a thumbs up from Mr. Horn. It'll be the first Tuesday of the month at 5 p.m. unless you hear otherwise. And until then, I hope your first month of this new year is a good one. Happy New Year, everybody, and so long until next month.